Hello and welcome to this talk on what to do with hip pain, brought to you by RX3, the CHAMP Consortium, HPRC. I'm Anthony Beutler, and you can see everything about me there on the screen, so I won't bother to introduce myself any further. Thank you. Glad you could join us as we talk about some common cases of hip pain today. There's a whole bunch of disclaimers on this next slide. So this one up here shows everything there is to know. The most important thing to know is that I work for the Air Force. They don't let me work for anybody else, so I have no relevant disclaimers. Let's get right into our hip pain cases. First of all, we're going to talk about hip pain. Hip pain is a dark and a murky place. Even for sports medicine professionals, it's a difficult thing. We'll talk about why that is. We're going to spend most of our time today talking about cases, victims and culprits, and what we really do with these things, and some evidence-based treatment for the things that are treatable really by most physicians. We'll talk about some variations on the theme. We'll talk about a few very simple tests you can use to screen out hip pain that needs really more attention and hip pain that you can probably do lots of stuff for. And then we'll try to answer some questions at the end. Our goal, as it always is to better diagnose and treat in musculoskeletal medicine today. So let's get right to it. Let's talk about hip pain being a dark and a murky place. First thing to realize is hip pain and leaf paperwork. I train a lot of sports medicine fellows. I always tell my fellows, beginning fellows especially, when they come out and they say, oh, I've got some hip pain, I say, well, why don't you go ahead and fill out your leave paperwork before you go back into that room, because you could be there for a very long time. Why is that? Why does hip pain take so long to sort out? Well, one of the main problems we have is which hip are the patient talking about? Is it their hip joint, the true hip joint right there? Is there hip groin that might be a little bit farther down than that and into the thigh? Is it the hip SI joint that they're talking about, around back? Is it really an SI problem? Is it their hip L-spine? We certainly have seen people with back pain who come in thinking that they have hip pain, and that is very common. Is there lateral hip pain? That may be one of the more common sources of hip pain, and I think some of the easiest to treat, not that it gets better quickly, but the treatment for it is relatively straightforward. Is it their hip pelvis? Oh my goodness, something that's inside the pelvis or even the abdomen. Certainly, if your patient happens to be a female of childbearing age, it is criminal how many different things they have that might refer things to the hip or the lower pelvis you might have to worry about. So you got to be a doctor first, right? You got to make sure that if this hip is this really hip pain, or is this some other type of pain that's just being referred to the hip? That's one of the reasons that hip is so dark and murky, is it can be all those different things. It looks simple enough, but there's nothing simple about the hip. So, if this is a dark and a murky place, how can we bring you light in the darkness? Well, here's some links that I hope will be useful for you. There are some really great tools out there to do that. So if we click on this top link right here and click away, what do we find? It'll bring you to this page right here. The first thing I'd like to call your attention to is this hip pain algorithm that's right here in PDF form. This hip pain algorithm will help you. We'll work through it with each of our 3 cases today to sort of help you figure out, is this hip pain something that you can deal with, or is this something that needs to go see some more specialty care? There's also a hip pain rehabilitation handout, and we'll go through that just briefly today too. We'll show you what that looks like. That's something that you can give, assuming this is hip pain you can really treat and wrap your arms around. You can give that program safely to people who pass through the algorithm noted up above here. There's the hip pain rehab webinar presentation. That's what you're listening to right now. So maybe you got there through this link, maybe through another link that we're out there on the video for. And then this hip rehabilitation program that we have in PDF form, we also have in video form, that your patients can access these videos at the gym when they're at the point of care, at their home, whatever it needs, and some very helpful videos to have some stuff through this. So we hope that this right here will be a light in the darkness. Let's look into some of this stuff. First of all, the hip pain algorithm, what does that look at? So the hip pain algorithm looks like this. It's pretty simple. Asks a few questions, yes or no answers, and guides you through whether you can continue to evaluate this or whether this hip pain needs a more detailed evaluation. We'll work through this in the course of our travels. Next thing to look at is this hip pain rehabilitation handout. What does that look like? This is a series of exercises, home exercises that your patient can do that really will help a large proportion of the hip pain that you will see in clinic. We'll get to that too as we go through our cases today. All right, so we hope this will be a light in the darkness for you. The hip pain is a dark place, but hopefully we'll see the light and get through it together. Let's work through it. Let's work through some cases. Let's look at what we have. First case here, we have a 36-year-old female. No past surgical history, really not a lot of exciting medical history. Left hip pain for over a week now. She doesn't remember any trauma. She may have banged in the door a few weeks ago, doesn't really remember. Doesn't remember any traumatic episode, to be sure. She describes this pain of running down the outside of her thigh, down to her knee. It hurts to get out of a chair, and certainly hurts to lay on that left side, and she's bothered by this. On exam, this is a normal appearing hip. There's no swelling, and she does not have any pain with hip internal rotation. That's important. Again, no pain with hip internal rotation. It's getting so bad that she says, gosh, over this past week, it's gotten so bad I can hardly walk. It was just a dull ache before, now it's getting kind of sharp. Doctor, you must help me. What's your diagnosis? Well, before we get too much into diagnosis here, let's go ahead and talk again about hip pain and leave paperwork. We talked about this before, all these things that it could be, but certainly before we fill out our leave web, so our leave paperwork to go to the exam room, we might want to go ahead and press on that trochanteric bursa, because that might help us decide that this is going to be something that we can deal with. So let's go ahead and work through our algorithm and just sort of see what we do. All right, so on brief history, does she have a past injury, some sort of surgery to her hip, some sort of thing that's happened before that suggests this is a recurrent problem? If yes, we got to go to a detailed evaluation. Thankfully, no for her, right? This is the first time this hip has bothered her. This is a brand new problem for her over the course of this week, so we get to go out here to know. Is there any sign of systemic process, rheumatologic, metabolic? You know, does she look like the cancer man from X-Files? No, she doesn't. There's nothing on there, so we're going to follow this down farther to the no part of the diagram. All right, then we can begin a limited physical exam. That was pretty quick. We just took a quick history, and now we're to physical exam. What do we really want to know on physical exam? First of all, is this a grossly normal appearance? We want to inspect the area of pain, and we must be able to say, is this pain actually coming from the hip? Point to it. Where is it coming from? And can we reproduce that pain? Certainly she has that, or pain on the lateral side of her hip. So, so she has grossly normal appearance, and we're able to look at this. This thing is swift. I just saw that. So we're going to go on to painful hip internal rotation. Does she have painful hip internal rotation? And she does not, and that's important. So if she has no painful hip internal rotation, then again, at this point, if it's a pain in the hip, but not painful hip internal rotation, that means there's low likelihood that the cause of pain is from anything that requires specific medical or surgical intervention, and we can probably safely proceed with general rehabilitation for hip pain. Certainly for this patient, that's true, right? If we're going to press on, so we're supposed to look at what internal rotation looks like. There's a couple ways you can do internal rotation. Grab the patient's foot like this, and just rotate their foot to the inside. Internal rotation here. If that bothers them, that's what we're looking for. You can get more details by clicking on this link. I like to do my hip internal rotation this way. It's a little more complicated to explain, but I like the patient at 90 degrees of abduction, 90 degrees of hip flexion, and then I'll rotate the hip internally this way. The foot actually swings out with internal rotation of the hip this way. Doesn't make a lot of sense to think about, but try it. You'll see it's true. Internal rotation of the hip that way is also a decent way to do it. Thankfully, our patient doesn't have painful hip internal rotation, and so we can go ahead and just follow off with this general rehabilitation program that we talked about. So this person, as you've probably figured out long before now, this person has trochanteric bursitis, or trochanteric pain syndrome is what we maybe would call it now. How did we know this was trochanteric pain syndrome? What were our clues to our diagnosis? You guys probably figured it out slides ago. You've been waiting for me to get there. How'd you know? Well, you might have known that lateral hip pain certainly is often trochanteric pain syndrome. So anything lateral certainly makes you think that. Pain that runs down towards the knee is a good clue for that. This can be a wide spectrum of pain. Sometimes this pain is just an annoyance. Sometimes it really does stop people from getting up out of the chair and walking. They're almost completely disabled by this pain. So be aware it comes in all different flavors and shades. No matter the history, always press on the troch bursa, not because the troch bursa can't be sore and other things. The troch bursa gets irritated and sore for a lot of different things that people have, but certainly if that seems to be their pain, if that seems to be the majority of their pain, often you can do something about trochanteric pain, whereas, as we'll see with other things, other types of hip pain are much more difficult to really treat adequately. What else is different to diagnosis? Well, anything. Right? You got to be a doctor first. You got to make sure that this is really truly hip pain, and we talked about why that is because of all the things that refer pain to the hip. So be a good doctor. All right. Let's look at some victims and culprits. So if we look at victims and culprits, right, victim is the thing that is being hurt, that is causing the pain, and culprit is what is causing that victim to have pain. So it's important that we not only identify the victim, but we identify the culprit. What is causing that to happen? What's the victim in our 36-year-old lady here? What is causing her pain? Well, certainly her pain is coming from the trochanteric bursal region. It might be from the bursa. We don't really think that anymore, but it certainly is from that region. Something's causing pain there. So the glute med insertion is probably what we think of more now. Let's talk for just a second about treatments then. What treatments could we use? What do you use for trochanteric bursal pain? We could use rice, NSAID, phonophoresis, steroid injection, all these things that we use. But I'd just like to call your attention to the fact that all of these treatments here are directed towards the victim, whether it be the bursa, whether it be the glute medius insertion. These are victim-based treatments. They're not doing much for the culprit. What is the culprit? What is causing our trochanteric pain to begin with? Before we answer that, let's go ahead and just get you to answer this question. What is the best evidence-based treatment for trochanteric bursitis, trochanteric pain syndrome? Should you use NSAIDs and stretching? Should you send your patient to physical therapy? Should you say, well, let's do some rice on that. Let's rest, ice, slow return activity, because, I mean, let's face it, it's tough to compress the hip. It's a big area to be compressing, right? Or is the best thing to do a steroid injection with a physical therapy chaser? Send this person to physical therapy after we've injected the hip. Well, we'll talk about that, and we'll see what the literature has to say about that as we go along. Now, I promised we get to the talking about the culprits, so here they are. Most of the time, the culprits for trochanteric pain are coming from the hips themselves. That's weak gluteal muscles, specifically the gluteus medius, the gluteus minimus. There's some thought that there might also be an aspect of a tight iliotibial band that might be causing our trochanteric pain. We've all been taught that. I'm not convinced that that's true. We'll talk about why as we go through. Training error can certainly play a role. People who run too far, too fast, who do too much too soon, that can certainly cause trochanteric pain syndrome. So that could be a culprit. Anatomic alignment can cause this. There are certain people who are aligned in such ways that they're just going to have more hip pain than other folks, especially on the lateral hip. So those are all possible things, with, I will say, weak gluteal muscles being by far the dominant culprit that we see most commonly. All right, why is that? Why are we talking so much about the gluteus here? So the gluteus medius, which is actually not much of a butt muscle, but more of kind of a side muscle, it attaches more along the sides, and the minimus is more a side muscle. The gluteus medius is key in all this because its job is to keep your hips level. If your gluteus medius is not strong enough, it allows your hips to fall into this position that we call Trendelenburg, which Trendelenburg is just never good. This isn't where you put your head down the operating room. This is a Trendelenburg gait, where your hip sags, where you're standing. I'm trying to stand on one foot, single leg stance, but instead of your hips staying level, the off hip sags, or your the side that's not being supported by your leg sags, and this we call Trendelenburg gait. That's bad. Biomechanically, this sets you up for all sorts of overuse injuries. Trochanteric pain syndrome, trochanteric bursitis being one of those many that it sets you up for. All right, so how does this happen? How can trochanteric pain happen? Let's go ahead and look at this diagram here that might help us. So as we're looking at this, what we find is that here's our gluteus medius muscle right here, right? And its job is to contract to keep the hips level. If gluteus medius is not strong enough to contract to keep this level, if it can't do that, then it will go ahead and drop the hip like this into Trendelenburg gait. Now, look down here at the trochanteric region. You have running over the trochanteric region here the tensor fascia lata, or the iliotibial band that run over the top here. If every step that you take, your hip is falling into Trendelenburg because your gluteus medius is not strong enough to hold it level, what you get is you get kind of a shaking, rattling gait here, and that causes friction, irritation, or certainly, if it's not bursal pain, then irritation and breakdown of the gluteus medius muscle where it hooks to the trochanter, but you get pain in the trochanteric region because your pelvis is basically not stable. Every step you take is causing either an eccentric contraction, eccentric stretch of the gluteus medius, or an irritation of the bursa that's causing that to happen deep underneath the iliotibial band. And that's how this weak gluteus medius muscle contributes to trochanteric pain syndrome. So what do we do? Well, you got to treat the culprit, obviously, and that's pretty easily seen. But you want to do gluteus medius strengthening. You can do single leg step downs, lateral leg lifts, hula girl exercises. Some of the best exercises out there can be found in our hip pain document that we talked about before, right here. So the hip pain document will lead you through a very, very good, what I call lower core strengthening program. That is helpful for many different types of hip pain, including trochanteric pain syndrome. So that'd be a good place to start your rehab right there. Iliotibial band stretching. We also talk a little bit about that. It's a good idea in theory. I'll tell you that practically it gives me very mixed results. I have people who seem to have very loose IT bands already. who have very, very wicked trochanteric pain. And I look at them and say, well, we can stretch your IT band if we want, but it's already kind of loose and you still have pain. So strengthening seems to be work out more. Conversely, it's true too. There are people out there who have wickedly tight IT bands and never had trochanteric pain in their life. So I really do think that it's more a problem of gluteus medius strengthening than IT band stretching. If you happen to have a tight IT band and gluteus medius pain, is stretching going to hurt you? No, and you look kind of sexy trying to push the wall down, so you might as well go ahead and do it. But I think that it's a good idea in theory with mixed practical results. Certainly helps sometimes, but don't forget to do your strengthening while you're worried about all that buff stretching that you're doing. For treatment of trochanteric bursitis, I often will inject first and ask questions later. Why is that? Steroid injection versus NSAIDs, there's no head-to-head studies, but in retrospective studies, certainly patients receiving an injection are 3 times more likely to be pain-free 3 months later than patients that did not receive that injection. We'll talk through that study a little bit more later on. So with that, I like the idea of people being 3 times more likely to be pain-free after 3 months, because I don't want these people clogging up my waiting room, coming back and seeing me over and over as we wait for them to do. I will certainly say that if this pain recurs in your older folks, or certainly if your patient is young and athletic, you need to be attuned to the fact that there may be other culprits, right? And we've got to find and treat those culprits to make sure that we're not missing anything out there. There could be other culprits on our list that we'd have to look at. So let's get to the Gramsci's, which are great research that might be practice changing. Important for you to know that our good colleague just down the road from us here in Washington, D.C., Dr. Gary Ho, published recently about this greater trochanteric pain syndrome. It's certainly more than a bursitis and iliotibial band friction. What he found is that he reviews the cause of lateral hip pain and found that trochanteric bursitis is often implicated in the literature, but actually we just don't see it. We can see the trochanteric bursa, if you will, very well with ultrasound, and when we look at these people with trochanteric pain, the bursa is not any more swollen than it would be in a normal person. In fact, there's seldom any fluid there that we see. We have all these different treatments that seem to address, like we talked about, that can be victim-based if we're not careful. We're doing too much for the victim and not addressing the culprit, which is really best addressed, like we talked about, with therapy, with strengthening of the gluteus medius and gluteus minimus muscles underneath the problem there. So another good trochanteric pain article here is from the Annals of Family Medicine, way back in 2011, a little bit old now. 120 patients visiting Dutch GPs who received either a steroid injection or usual care, which is home PT and NSAIDs, for their trochanteric pain syndrome. And they followed these people forward and found this. They found that at 3 months, a third of the people with usual care were feeling better and had recovered, whereas 55% of people had gotten better in the steroid group. Now just imagine if you would have given them a steroid and also given them a nice home PT program like we have provided for you on these links that we've seen many times now. Think how much better they would have been at 3 months. So maybe someone wants to redo this study with steroid injection plus home PT, and then home PT plus NSAIDs, and tell us what we find out. But certainly it looks like the steroid injection is better than home PT and NSAIDs, so that would be a good thing to do. At 12 months, again, there's no difference between us because the PT is going to catch up for those folks and get better. So as we look at this, we want to make sure, of course, we talked about that our victim is often the trochanteric bursa. It's just the victim, so you might want to direct a steroid injection at it, but these other victim-based treatments are probably not entirely worthwhile. We do want to look at our culprits, and our most common ones there are weak gluteals, maybe a tight IT band. We can sort of look at training area in our trainees. But strengthening, stretching of that is going to be important, especially the strengthening of the gluteal muscles. So our first-line treatment is to strengthen the core and strengthen the hip. Second-line treatment is certainly consider a steroid injection. I will often do those two simultaneously. And then certainly for people who are not getting better, I'm going to send them off to supervised physical therapy. I can think about shockwave therapy, but I haven't done that for years for people, really. Shockwave therapy is painful. It's hard to get at. It's time-consuming. And most folks, really, really the vast majority of folks will do well. This is not a fast recovery. Rome was not built in a day. Trochanteric pain syndrome does not go away in a week, but it does go away over the course of about 3 to 4 months of really good, solid physical therapy. And a steroid injection makes them feel better a lot faster. All right, that's our first case. Let's go ahead and jump to our second case now. Is a 45-year-old male who needs to spend less time in a Speedo with no past surgical history, right hip pain for 6 months now. Okay, He's a little bit of a triathlon racer. He wants to get out there and do his next triathlon. He had no trauma. Noticed it after long runs 6 months ago, but now he says, my right hip hurts all the time. Aches all the time. Maybe it's starting to wake me up a little bit at night with this pain. Dull, achy. It's in the groin region and occasionally runs down the inside of his thigh. Not the outside of his thigh, the inside of his thigh down towards his knee. On exam, he has normal appearance, no swelling. Everything looks fine with this guy. But he does have painful and limited hip interrotation when we do our examination. He really wants this fixed so he can get to his next race. Doctor, do you have a diagnosis for what this might be? Well, again, before we get to our heart into the diagnosis, let's just go ahead and trace through our algorithm. So let's just look here. Is this a previous problem? Does he have previous treatments? Does he have previous surgery? No, he does not, so we don't have to go over here just yet. Is there a systemic process? Is this like a rheumatologic condition or a metabolic condition or either the polyarthralgia or polyarthritis? Does he have some strange tick bite rash? No, it doesn't have anything like that. So we'll go on farther down our algorithm this way. Begin our physical exam. On exam, was it normal in appearance? Well, yes, it was. So we'll go down here. And does he have painful hip rotation? Yes, he does have painful hip rotation, as a matter of fact. Well, then we need to look at over here. This requires a detailed evaluation. We can't go down to this last box because this guy has painful hip interrotation. Now, as part of our detailed evaluation, we'll just say that we order a really fancy schmancy test, like a hip x-ray. Oh, how fancy can we be? Well, first we're going to talk about interrotation. So here's an interrotation again. We did this, it caused him pain. We did that, it caused him pain, and it was kind of limited. It didn't move very far. All right. So we couldn't go down. There he is, our hip x-ray right there. And as we look at this guy's hip x-ray, what do we see? We see a couple of things. First of all, this guy's hips are jacked up. So here's his left side. The left side's kind of messy. He has a very short femoral neck, and certainly the ball, this is not much of a ball, right? This looks like a playground ball that's been run over by a tractor somewhere in Iowa. But, this ball is kind of flattened and oblong and oval here now. It certainly doesn't look very good on the left. His right is where he's most symptomatic. Ooh, look at all this sclerosis here, all this osteoarthritis type change here, the femoral acetabular joint. That's not good. Look at this ball. This thing even looks more squished on the other side. Again, a very short femoral neck, and we have some bony things here. He has bilateral here, but certainly worse on the right. This certainly looks like a femoral acetabular impingement from osteoarthritis with what we would call a cam deformity, where that no longer looks like a nice ball that fits in there, but he's got an oblong, kind of an oval head. How do we know this is what this was? Well, he had hip pain. That's always a good one. He had this painful internal rotation, right? And some of you might be familiar with the Federer test, the flexion, adduction, rotation test. That would certainly be screaming positive on this guy. Those are how we know. Again, femoral acetabular impingement, hip arthritis can cause a wide spectrum of pain. It can happen in young people, like our young people here. It can happen in old people, so something you need to be aware of. Again, your different diagnosis here is just about anything because you're dealing with the hip. Be a good doctor first. How do we treat femoral acetabular impingement syndrome from OA? This is really an involving subject. This is why this is one you probably shouldn't go alone. This is one that needs to go someplace else. You can certainly send these people off for conservative treatment, right? If you've got femoral acetabular impingement, happen to see it, happen to get the x-ray, happen to move along. Core strengthening can be very helpful to these folks. I would recommend a formal physical therapy evaluation, preferably with a physical therapist who's skilled in kinesiology, to be able to really maximize the limited movement that these people do have, to see if we can get them back to max function. But it might be more than this. We might need to send them off to see surgeons. I think hip arthroscopy is in its infancy. We don't understand everything we know about hip arthroscopy. We certainly don't understand everything that might be good for these. We've only been doing hip arthroscopes for a very short period of time. We certainly don't have any data on the long-term outcomes of these things. But you should be aware that hip arthroscopy is not, at the time of this recording, covered by TRICARE. So if you have a patient who wants to get hip arthroscopy, they have to get it inside the military network, which is can also be a difficult thing to do because there aren't that many active duty surgeons that do hip arthroscopy, and certainly you want people that are good at it. So again, this is one that you probably should not go alone. If you've got femoral acetabular impingement with OA or without OA, and it's causing symptoms, you really need to probably get some help on that and get a multidisciplinary team going. Ultimately, these people might need a hip replacement. We want to stave that off as long as we can. All right, again, how do we know this? How do we know we got here? Again, we got stuck at this hip interrotation, and that's let us know. So being well versed in what hip interrotation looks like normally and what it looks like abnormally can be very useful and helpful for us, to be sure. All right, let's talk about some variations on the theme. We've talked about 2 adult cases. I want to jump into a peds case because kids get hip pain too. In fact, here's an adolescent, Emily. Emily's an 11-year-old triathlete who came in complaining of bilateral medial knee and thigh pain. So why are we talking about medial thigh and knee pain if we're talking about hip pain? Well, for the past 2 weeks, Dad says, she's kind of running like a gorilla. She kind of lumbers. She doesn't really run anymore. And her mom says, I just thought she was limping. Dad's description was maybe less elegant. What's a differential for Emily? What things do we think about in 11-year-olds who have thigh knee pain? Well, certainly they can get osgood Schlatter. That's a very common problem of the knees. They could have patellofemoral pain, but there's some other things that this could be too, especially with this medial thigh pain that she's getting. It makes us think about a slipped capital femoral epiphysis or a skiffy. As we go ahead, there are other things it could be as well, though some of those are bad. We don't want those. As we go to physical exam, what I want you to pay attention to on Emily is that when we examine Emily, we find that her knee looks peachy, right? Both knees, fantastic. They look fantastically normal. Certainly not osgood Schlatter syndrome. If we don't have any tendon palpation or tibial tuberosity, we can't have osgood Schlatter. What we do find, though, is that we look at her hip. She has something we call obligate external rotation when we bring her hip into flexion, which means we try to flex her hip up. She doesn't go straight into flexion. She actually externally rotates. It has to externally rotate in order to get any hip flexion. That's not a good sign. What that means also is that when we go to try to internally rotate the hip and put her back in neutral, she doesn't like that. She actually says, "Ow, that hurts." It feels very tight. And she says, "Yeah, that causes my medial thigh and my knee to hurt on the inside." So we reproduce her pain not with a knee exam technique, but actually with a hip exam technique. And this is common that we see in kids. Emily does have a slipped capital femoral epiphysis. Who gets this? Girls get it a little bit earlier than boys. That's because they go through that growth spurt earlier. Most commonly affected, you may have heard that this is a disease of obese black males, but there are certainly a lot of skinny white girls that get this too. So don't be fooled by that, even though it is more common in kids that are a little heavier, certainly in kids that are rapidly growing. It's an unstable growth plate fracture. If you look right here, here's the femoral neck, here's the femoral head. Kids have this growth plate across here, and you can see that this one is actually slipping off. It's the most common hip disorder in adolescence, something we have to be aware of. Now, on imaging, we want to get pelvic X-ray as soon as we can. There's some debate about if getting a frog leg. We often don't want to stress this. What does it look like? This is a normal appearing hip on X-ray. I think it looks like there's a cone with ice cream perched proudly on top here, right? So let's look. Here's our cone on this side, and our ice cream, is headed for the cement below. Nobody's happy when their ice cream falls off the cone, orthopedic surgeon or toddler. And really, they're about the same when you think about it. So now, so this would be a bad X-ray over here on the side. So now, when do we think about slipped capital femoral epiphysis? Certainly, any adolescent that comes in complaining of hip pain, thigh pain, knee pain, we got to think about it. And then on exam, we're looking again for hip limited internal rotation or obligate external rotation with flexion. So they can't internally rotate their hip. It's painful, it's sore, it's limited. It makes us think about that. What do we want to do? They go to X-ray next in a wheelchair, right? We're looking for Klein's line. Klein's lines are these lines we draw across the femoral neck right here. This is a Klein's line. You can see it should take up some of the ice cream there. Some of the ice cream should fall on the outside of Klein's line. Over here you can see this is abnormal because we don't have any ice cream on the outside of Klein's line here. This is an abnormal hip. So, and again, frog leg, which we may not want to get, we can certainly see it a little bit more discreetly there. Remember that these things can be bilateral. So although this is clearly abnormal, what they're going to do with this is we're going to look with MRI next. Even if both sides look like this, if this exam were concerning to me, I would get an MRI and look, because this side may also be abnormal. And in fact, in this patient where this X-ray was taken, this side was clearly abnormal. We put a pin across this side, and it was okay. But this side was also abnormal and hadn't started to slip visibly on X-ray yet, but on MRI showed signs that it was about to, so we put a pin across that side too. Remember that decreased or painful internal rotation is key. This is what we're stomping our foot about, right? That if you have decreased or painful internal rotation of the hip, that is never a good thing. What do you think about when you see a 3-year-old girl with a fever and decreased and painful hip internal rotation? What is that? Well, that's probably a septic hip. That's not a good thing. What about a 5-year-old boy who's just had a bad cold who also has painful internal rotation of the hip? It's probably toxic synovitis. Not necessarily a bad thing, but certainly something you want to be aware of and watch closely. What about an 8-year-old male child that comes to see he's well, but his mom says, he walks a little funny. You look at his hip. He has painful interrotation. It's limited on that. What's that going to be? That's probably Leg-Calf-Perthes disease. We can talk more about that later, but that's not necessarily a good thing. Something we want to watch as well. 12-year-old limping female who comes in with decreased internal rotation that's painful. Well, you know that one. That one you just saw right now. That's a SCFE, a slipped capital femoral epiphysis. That is not a good thing. Needs treatment right now. An 8-year-old female cross-country runner with decreased internal rotation or painful internal rotation of the hip. That's a stress fracture. That also needs treatment right now. A 48-year-old male former airborne guy who comes in complaining of painful hip internal rotation. That's probably osteoarthritis of the hip. And a 72-year-old female whose status post-fall is fallen down and you interrotate the hip and she yells in pain. Well, again, that's probably an insufficiency or a pathologic fracture of the hip, and that's not going to be a good thing for her either. So really, across the age spectrum, from 3 years old to 72 years old, painful, decreased hip internal rotation is a marker for bad things. So that's why it's its own step on the algorithm. It's its own place to get there. Decreased internal rotation of the hip is bad. So we hope that this has been helpful to you. We hope that these lights in the darkness have been helpful. We hope that you can apply these things to these cases to these algorithms we have here. Here's your cheat sheet. Here's your main page for hip pain. You can look at the hip pain algorithm, which we've looked at several times. We can look at the rehabilitation for the rehabilitation program in PDF form, or we can look at it on the video side, or we can go back and watch this lovely webinar and look at these slides again. There's lots of things we can do. Remember, as you're working through the algorithm, to go through carefully and look at what you're doing. Make sure you're looking closely at decreased hip internal rotation, because that's not a good thing. With that being said, if you have any questions, please go to the Find the Expert button on the HPRC website. Again, you can find that on our web links here. Click on the Ask the Expert link. Send us your questions. If you think we've stretched the truth in any way here with our hip pain stuff, we'd be happy to hear any questions that you have. A big thanks to the folks who did our modeling for us on our pictures today. We hope you have a great day in treating your hip pain in your clinic. Goodbye.